Hello everyone and thank you for tuning in. My name is Isa Kadiri. I am a PGY2 internal medicine resident at Beaumont Hospital in Dearborn. Today we'll be discussing Beaumont Mortality Risk Index. So there are many mortality risk calculators that exist out there that we use as clinicians on a daily basis to improve the accuracy of prognostication and allow us as clinicians to risk stratify our patients. These calculators are very important because they allow us to make a more robust, informed clinical decision regarding our patients, and they are, in a sense, reproducible. There are multiple calculators and risk scores that exist out there. I've just listed a few of them that we might use on a daily basis. As clinicians, we face many challenges when using these calculators. Some of them require manual assessments, which can be very time consuming and subject to intraoperative error. Some of them are very specific, or most of them, if not all of them, are very specific to certain pathologies. And none of them are actually in real time. And what I mean by this is some of them are based on ICD-10 codes, some of them are based upon post-discharge evaluation, and then some of them require a very comprehensive past medical history. And ultimately, these things continue to change during the course of a patient's hospitalization or admission. For this reason, it is not unreasonable to say that predicting mortality in patients with very diverse medical conditions and a diverse population is actually very difficult. We as a team got together and wanted to develop a very simple automated mortality risk calculator that is available in real time and can be applied to all patients or all inpatients. Our primary aim in developing this calculator was trying to create a correlation between mortality and a patient's score with this calculator. Our calculator is based upon a set of 25 lab values that have been defined as independent predictors of mortality. This is the list of those 25 lab values, and we basically took, for example, glucose or blood sugar, and we said that the calculator would calculate a score if the patient's glucose was less than 30 or greater than 350. And you can see with hemoglobin, we did the same thing. With lactic acid, we did the same thing, and so on and so forth. These lab values were based upon an extensive background research and looking into different types of studies that identified lab values as independent predictors of mortality. This is not an exhaustive list. This is just a number of studies that we looked into. And you can see that some of these studies were able to identify ALT, AST. Others looked at hemoglobin levels and anemia in patients with septic shock. Other studies looked at troponin levels and so on and so forth. We then took our calculator and gave 1 point per abnormal lab value. We embedded this calculator in our electronic medical record system to provide real-time scores. We applied this score to all hospitalized patients across the Beaumont system that were greater than the age of 18 and admitted to the medical, surgical, and ICU floors. We had a total of 2,460 patients, and ultimately we identified patients that had passed away at day 7 and day 30. We then went ahead and calculated statistical analyses on each patient. These are the results. We took 2,460 patients. We calculated their score at day 0. And then we followed these patients at day 7 and day 30. At day 7, we went ahead and identified the patients that were dead and the patients that were alive, and we categorized these patients based upon their score on day 0. We then went ahead and calculated statistical analyses on all of these scores, and this allowed us to identify a score that was statistically significant and also provided a robust sensitivity and specificity, and that score was greater than or equal to 2. At day 30, we were able to reproduce those same results. To better visualize this correlation between the odds ratio and the calculated score, I plotted our numbers The blue line is at 7 days and the red line is at 30 days, and as you can see, they are nearly identical. Now the results suggest that mortality at 7 and 30 days, meaning a person dying at 7 and 30 days, is approximately 5 times more likely in a patient with a score of greater than or equal to 2. And one can argue that it's approximately 30 times, or at least 30 times in a patient whose score is greater than or equal to 8. Now, how can we use this calculator in our clinical practice? Well, as clinicians, if we can identify patients that are at an increased risk of death earlier, this will prompt earlier interventions. And it will allow us to initiate a discussion not only with the patient, but with the patient's family and loved ones. And then it gives us the ability to discuss goals of care and even in some cases end-of-life planning. Moving forward, I wanted to be able to fine-tune this calculator, and this can be done so by better defining abnormal lab values using statistical analyses. I wanted to be able to take a deeper dive into the literature and possibly identify other routine blood tests associated with mortality, and ultimately taking this calculator and embedding it into the electronic medical record for a clinician use. And what this might look like is that on a clinician census in their electronic medical record, they would have a column that would identify their mortality risk, and this would be updated in real time. And if you were to hover over this number, it would identify those lab values that were abnormal. I wanted to thank everyone for tuning in and listening. If you have any questions or comments, please list them below.